Good morning, class. This Monday morning, we're going to be talking about genitourinary disorders. So the first disorder we will discuss this morning is enuresis. And I would like to discuss two types of enuresis before we get to our case study. The first type is primary, meaning the child has never been free of bedwetting for any extended period of time. And then secondary, a child who has started bedwetting after development of urinary control. In other words, they had developed control, but for some reason, whether it be psychosocial or physiological, they have started wetting the bed again. So let's talk about Chloe, and we'll go into some detail about these. So Mrs. Williams brings her 7-year-old daughter Chloe to the pediatrician's office because she has been wetting the bed 2 to 3 times a night for the past month. According to Mom, this is unusual for Chloe since Chloe has been potty trained since she was 2 years old. And looking at her history below, which data may be pertinent for this situation? So let's go through our list of pertinent data here. We will select all that apply. So Chloe is a newly diagnosed type 1 diabetic. That is significant because she has some bedwetting related to diabetes. Her parents are recently divorced. Yes, that is the psychosocial issue I had talked about just a moment ago. She drinks apple juice with her lunch. That's okay to drink apple juice with her lunch. We just avoid all beverages after 1600 4 p.m. She keeps a bottle of water near her bed for when she wakes up thirsty. No, we don't want her to do that. We need to provide some education about that. Her bedroom is upstairs with no bathroom close by. Again, that is a problem. We do not want her to have to get up through the night to go downstairs to the bathroom when she needs to go quickly. She does well in school and has lots of friends. That's good. That's age appropriate. That's not anything we would worry about. Her older sister also has episodes of bedwetting. Again, that is significant and pertinent because it is somewhat genetic. She suffers from chronic constipation. Yes, that is true as well because the pressure of the stool on the bladder can cause some issues with bedwetting. So our next question on your packet would be involving nursing care. What would be included in your teaching plan, nursing care for Chloe and her family? Select all that apply. Number 1, avoid caffeinated beverages after 1800. Now we're going to avoid caffeine altogether because it's a diuretic, so we don't want her to have caffeine. Increase fiber in her diet, again to prevent constipation. An appropriate punishment would be grounding her for a week. No, that is not good. We don't want to punish her. This is something she can't control. Refer child and family to support groups, yes. Have her help change her bed linens and clothing following each accident. Yes, this is good. We don't make it punitive. We just get in there and promote self-care and say, Chloe, let's get your bed made and get you back to bed. 6, encourage the child to eat as many fruits and fruit juices as she would like prior to bedtime. No. When do we stop drinking? 1600 4 p.m. Encourage her not to hold her urine during the day. That's correct. Encourage use of diapers pull-ups until the episodes of enuresis stop. No, we're not going to regress and make her wear pull-ups or diapers. Wake up the child during the night to void. Yes, we want her to wake up through the night on scheduled times for this is a bladder training kind of thing. So we want to make sure that she's getting up through the night to void. The first medication we will discuss in the treatment of enuresis is DDVAP or desmopressin. We're going to talk to the family and the patient about how to handle this and then how to notice if we're having any adverse reactions. So first, we're going to talk about it. It can be oral or nasal. Second, monitor intake and output. We want her urine output to resume during the day and only be suppressed at night. Restrict fluid after dinner. We're going to restrict fluid after 4 p.m., 1600. Give at bedtime, yes, because like I said, we only want her urine to be suppressed in the evening while she's sleeping. Store nasal prep in the refrigerator and inform family of possible adverse reactions. So a few of those can be more serious adverse reactions. We can have a drop in our sodium because of dilutional hyponatremia, resulting in a headache, drowsiness, confusion, nausea, vomiting, muscle cramps, restlessness, and seizures. So if we see any changes in the child like those that I've just named, we need to have the family call the healthcare provider. The next medications we will talk about are tricyclic antidepressants and anticholinergics. So What we need to worry about with tricyclic antidepressant, tofranil imapropine hydrochloride, is that it can increase suicidality in children. So we want to monitor for effectiveness. Length of treatment will be 6 to 8 weeks with a gradual withdrawal, gradual tapering of the dose. Want to administer it with food, take 1 hour before bedtime, teach regarding these adverse reactions, avoid sun exposure, avoid other over-the-counter medications. So anticholinergic, this is going to help with bladder spasms. So we want to monitor for effectiveness and instruct family about possible adverse reactions. So continuing on with complications of enuresis, emotional problems is the big one, because she is 7 years old, and most kids at this age, this is very distressful for them because they have not had anything like this happen. They've been toilet trained since they were young, and this affects even their social life, being able to go to sleepovers, see other children. They get very embarrassed by this. So we're going to support the child and the family by listening to concerns and correcting misperceptions. In other words, this is not because she's a baby. This is because she has some physiological things going on, some other factors that are causing her to bedwet. Involve the child in teaching and management. Make referrals to appropriate resources, which would be support groups, counseling as necessary. So client education, we would be assisting the family and the child to understand the emotional aspects of the disorder. Like I just said, lots of stress and embarrassment with this. Early interventions can alleviate long-term emotional stress. Next, we'll talk about urinary tract infections found in Chapter 24 of your text. First, I'd like to discuss some of the more common risk factors for UTIs, then we will progress to the case study. The first one is urinary stasis, where the patient is not urinating often enough for some reason, and the urine is just allowed to sit in the bladder. Urinary tract anomaly, some anomaly where we would have a blockage, some sort of disruption in the flow of urine. Reflux, again, that is a blockage not only in the ureter, but in the way the ureter is implanted into the kidney, so urine is going to reflux back up into the kidneys. Constipation, because of the size of the stool pressing on the bladder. Uncircumcised males that are not having proper hygiene completed on them, and the bacteria will build up underneath the foreskin. Females, the urethra's close proximity to the rectum allows E. coli to enter the urethral tract. Also, synthetic tight-fitting underwear or bathing suits causes moisture to stay in one spot, and it makes it more likely for an infection to form. So we want to use cotton underwear that are breathable, that dry quickly. Also, in older children, adolescents who are sexually active, we might see the female having a urinary tract more often because of the short urethra and how bacteria can get into the urethra during sexual activity. So we would instruct the family or the child to make sure after sexual activity that she urinate. So let's read the case study, and then we're going to go on in about assessment findings. So case study is Kate. She is 10 years old. She's brought to the pediatrician's office by her mom. She has been complaining of pain while she urinates, vomiting, and increase in thirst. Mom became alarmed that there was a slight blood tinge to the urine on the toilet tissue after Kate wiped herself. A UTI is suspected. So we're going to go on to the next slide to talk about physical assessment findings. So what other possible physical assessment findings would you obtain while talking to Kate and her mom? So we kind of addressed some of those in the stem of the question, but there are a few others we want to talk about with her. Of course, poor appetite, vomiting, which she has, slowed growth, increased thirst, enuresis, frequent urination, swelling of the face, seizures, pallor, fatigue, blood in the urine, edema in the extremities and even maybe around the eyes, periorbital in the morning, hypertension, and tetany because of our buildup of calcium in the urine and in the bloodstream. We're not emptying our bladder. We're not getting rid of waste like we should. So what laboratory tests would be ordered? So Kate will need a urinalysis and a culture and sensitivity. So we've got the culture back. So what findings would be indicative of a UTI? So what would we see on this culture and urinalysis? So you can see my little picture there. It says most wanted microbe, E. coli. So E. coli is the main culprit when it comes to urinary tract infections. Again, because the stool has E. coli in it, obviously, and that is getting into the urethra and causing a urinary tract infection. Other organisms can be Proteus, Pseudomonas, Klebsiella, Haemophilus, Staph aureus. So also our urinalysis would show a pH would be weak, acid, neutral, alkaline, positive for protein, glucose, ketones, leukocytes, and nitrites. So which of the following nursing actions would be inappropriate when preparing Kate for diagnostics? So let's go through these. There's select all that apply. So allow child to drink clear liquids up until the scheduled time for cystoscopy and IVP. So no, the patient would be NPO after midnight because this is a somewhat traumatic for the child. So sometimes the child would be under general anesthesia and intubated for the procedure. So we want to make sure that we keep the child NPO because we want to avoid aspiration should the child need to be intubated. Prepare child for catheterization if necessary. Yes, because we're going to get a urine specimen at that time again. Sedation is required for infants and young children. Like I said, it's painful and traumatizing. Assess child for allergy to iodine and shellfish if a contrast medium is being prepared. Yes. Monitor child after completion of procedure per facility policy. So the child might have post-op vital signs according to what kind of anesthesia that the child had to have for the procedure. So Kate is diagnosed with a UTI. Which of the following statements made by Kate's mom would indicate understanding, in other words, mom understands what you're telling her, of care and prevention of UTI? Select all that apply. When Kate is feeling better, I can stop her antibiotics. No, we want her to get her full course of antibiotics to finish killing the bacteria. I will teach Kate to wipe her perineal area from front to back. Yes, we don't want to do from back to front because we can introduce E. coli into the urethra. I will increase fiber in Kate's diet to avoid constipation and straining with bowel movements. Yes. I will encourage Kate to use bubble bath in her bath water to keep her perineal area clean. No bubble bath because the soap can break down the mucous membranes and then make them more susceptible and irritated to where a bacteria could take over. I will limit the fluid Kate drinks. No, this is not like with enuresis. We're wanting her to drink more fluid to keep her urinary tract flushed out. I will buy Kate all cotton underwear. Yes, that will prevent, like I said, the area staying moist down there. We need a breathable fabric to keep everything dry down there. So next we're going to talk about structural disorders of the GU tract and reproductive tract. So we're going to talk about three defects as below. So exstrophy of the bladder, hypospadias, and epispadias. Exstrophy of the bladder, I have a picture here. It is a little bit blurry, but you can see it's an inside-out bladder. It protrudes out of the abdomen, and inside of the bladder is exposed to the outside environment. So this is an emergency type situation. We want to get this child, she's going to be going to surgery immediately and get this corrected. And again, with the exstrophy of the bladder, the bladder's exposed, so we want to keep the bladder covered with sterile, wet dressings. Hypospadia. So you can see in the picture here the urethral opening is below the glans penis. It's underneath the penis, so below. Hypospadias is below. We have a urethral opening that is below the penis. It should be, again, at the glans penis, but it is below the penis. Epispadias, kind of the same, only the opening is on the upper side of the penis. So know the difference between those two disorders, and the treatment for them will be surgery. And something you might hear or see is that if the patient is to remain uncircumcised, because some of the foreskin can be used in repair of these two disorders of hypospadias and epispadias. So what must the nurse do immediately when a child is born with exstrophy of the bladder? I kind of said this a while ago on the slide, but let's go through these and select all that apply. Cover the exposed area sac with antibiotic ointment and gauze. No, we want to use just sterile water and gauze. Prepare the child for immediate surgery. Yes, this is a surgical emergency. Position the child in prone position. No, we don't want to position them prone because we don't want to risk rupturing that bladder. Cover the sac with moist, sterile gauze. So next we're going to discuss acute glomerulonephritis, or AGN. Let's talk about this case study first, and then I'll give you some details along the way. Case study is 8-year-old Addison presents to the emergency department with her mother with a history of strep throat 2 weeks ago. She was treated with amoxicillin orally for 10 days. Mom brought Addison to the ED before Addison's urine was visibly brown. So brown, tea-colored is often you hear it called, or cola-colored. Also, according to Mom, Addison has not been eating. She has been tired and very irritable. Upon assessment, Addison is ill-appearing and is complaining of a headache. Her symptoms indicate that she has acute glomerulonephritis, or AGN. So acute glomerulonephritis signs and symptoms include pink or tea-colored urine from red blood cells in your urine, dysuria, periorbital edema, facial edema that spreads to the abdomen and extremities during the progression of the day, high blood pressure, which can be mild to severe, and oliguria. So you see a picture here of the tea-colored urine, and you see the actual inflammation of the glomeruli on the picture here under to the left. So glomerulonephritis, we have a picture here of this fella. He is having the antigen-antibody complex in glomeruli. So we have inflammation, and that results in a decreased glomerular filtration rate. So we have antigen-antibody complex from recent strep infection. So over on the side, you see he's holding his head. So he has headache, probably from his increased blood pressure, facial periorbital edema. He's lethargic, low-grade fever, weight gain from the edema, and in the urine will be proteinuria, hematuria, oliguria, and dysuria. So here are our most common and pertinent laboratory tests in confirming the diagnosis of AGN. We'll have a throat culture, which is a swab, looking to see if we still have a positive strep. Urinalysis, renal function, a blood draw, antistreptolysin titers, and serum complement titers. Those are all associated with strep and their byproducts. So those are our laboratory results for AGN. So what interventions would be appropriate for this child and her family in the treatment of AGN? Select all that apply. So let's go through these and we'll discuss the appropriate and inappropriate. So monitor intake and output. Of course, we want to monitor and see if she has adequate urine output, which she probably won't because her glomerular filtration rate is low, so she's going to have a decreased amount of urine. Weigh every other day. No, we want to weigh her every single day. Same time, same scale, same clothes for consistency. Clients with slightly elevated blood pressure can be managed at home. No, we're not going to send a patient home knowingly with high blood pressure. We want to manage that at the hospital before we send them home. Restrict sodium and fluid intake, yes. Administer PO steroids as ordered, no. Provide age-appropriate diversional activities, yes. Administer antibiotics as ordered, yes. Cluster care to facilitate rest, yes. Instruct the child can return to normal activities as soon as she feels better. No, we're going to wait on the doctor's instructions before we let her return to any normal activities. So other interventions that would be appropriate here. If urine output and blood pressure are normal, the patient can go home. So we're not going to send her home unless we see a normal urine output, which is what? 0.5 to 1 milligrams per kilogram per hour up until they are 30 kilograms. And then we just go with the adult amount, which would be a minimum of 30 milliliters an hour. So maintain our urine output and blood pressure, monitor vital signs, monitor neurostatus for all the things I talked about earlier. We have an increased circulatory volume because we're not able to urinate because our glomeruli is all inflamed there. So we're going to look at possible changes in our electrolytes. So we want to monitor neurostatus. Fluid restrictions with periods of edema and hypertension. So anytime we have visible edema and hypertension, we're going to monitor fluids. Monitor for skin breakdowns. Okay, our swelling is going to cause some skin breakdown if we don't monitor for that. We want to elevate those edematous parts, make sure they're elevated and padded if necessary. Infection prevention, of course, turn and deep breathe to prevent any kind of respiratory issues. Monitor for fever, provide good hand hygiene. And of course, emotional support, because this is a kind of a lengthy illness and it can be serious and it can lead to renal failure. So we want to provide constant emotional support. So progression here, we have Addison. She is placed on a diuretic and antihypertensive. Which of the following statements indicate that Addison's mother understands teaching you've provided to her? In other words, she knows and understands, comprehends what you're teaching her. So select all that apply. So if Addison starts to feel dizzy, I need to stop her meds. Now, we don't abruptly stop meds. We consult with our healthcare provider. I will report any adverse effects to the doctor immediately. Yes. I will need to bring Addison to the doctor frequently to have her electrolyte levels checked. Yes. Addison will be able to eat as many salty foods as she wants that she's on these medications. No, absolutely not. I will learn to take Addison's blood pressure and monitor her weight every day. Yes, because even if she goes home with a normal blood pressure, there's possibility of relapse, so we want to make sure that we're checking her blood pressure and making sure everything is within normal limits. So next we're going to discuss nephrotic syndrome. And I don't want you to confuse this with acute glomerulonephritis. A lot of it will sound familiar, but then there's a lot of differences. Later on in the slideshow, you will see some comparing and contrasting of the two that I hope will help you not mix the two up. So I have the picture of the kidney here. He's saying, sorry, I keep spilling all of this protein. I hope that doesn't cause any more problems. Well, it will. So sorry, little kidney, you're going to be causing a lot of trouble for our patient here, Lucy. So let's talk about the case study, and then we'll go more into detail about signs and symptoms and nursing care. So Lucy is a 4-year-old child. She arrives at the emergency department with her father. He reports that Lucy has not been going to the bathroom as often as usual, and when she went about an hour ago, the urine looked bubbly to him. So bubbly or foamy, you might hear foamy. The nurse asks the father further questions, and he reports that Lucy has gained quite a bit of weight over the last 2 weeks, and she is tired all the time, not wanting to play at Mother's Day out like she normally does. So the doctor from these symptoms diagnosed her with nephrotic syndrome. So nephrotic syndrome here, we're going to talk about our first question here. What other data might validate the diagnosis or be a contributory factor? So we have select all that apply here. So hypertension. Now with nephrotic syndrome, we don't usually have hypertension because all of our fluid has gone out into our interstitial spaces and we have a decreased intravascular volume. So our blood pressure is not going to be high with nephrotic syndrome. As a matter of fact, it might be low. Gross proteinuria, lots of protein. Unlike with AGN, we have a little protein spilling, but we have lots and lots of protein spilling with nephrotic syndrome. So that's where you get that frothy, foamy urine, kind of like your Starbucks coffee, how it's all frothy and foamy at the top. When you get a urine specimen, that's what it will look like. 3, increased urine output. No, we will have decreased urine output. Paternal smoking in the home, that's not good, but it's not a contributory factor. Edema of the ankles, yes, we'll have edema probably all throughout. The edema will start in the morning in the upper extremities, the face, the eyes, and then we'll move down throughout the day by gravity. Hyperalbuminemia, no, our albumin levels will actually be low because we're urinating all of our albumin, all of our protein out into our urine. Facial and periorbital edema, yes. So let's talk about diet for Lucy. So Lucy is admitted to the hospital and placed on bed rest. The dietary assistant comes by with a menu for Lucy's lunch. What foods would be appropriate for the father to choose? So just choose one of these. And the first one would be the right selection: peanut butter and jelly sandwich, milk, and an apple, because it is high in protein and it's low in sodium. Of course, our other choices are high in sodium and fat and not good choices at all. So the first one of all of those is the best choice. So we're going to briefly discuss medications for nephrotic syndrome. The first one, corticosteroids, which we know we give those with meals to avoid stomach upset. Avoid crowds, because again, this can suppress your immune system, so avoid crowds. Let the family know that the appetite can increase and weight can be gained and the patient can have mood swings. Adverse effects include hirsutism, slowed linear growth, GI bleed, infection, and hyperglycemia. Now, albumin, 25%, this is to increase the plasma volume and decrease edema. So we're giving the child protein because we're losing so much protein through the urine. So we're going to administer this per institution policy. This is somewhat like a blood product in the frequency that we have to do vital signs. So we're going to look this policy up and see how often we need to take vital signs and do assessments. We're going to look that up in the hospital policy. Monitor intake and output and monitor anaphylaxis. Medications for nephrotic syndrome, continued. Lasix, of course, we want to eliminate fluid. We're going to get that fluid. Hopefully the albumin will pull that fluid out of the interstitial spaces into the intravascular spaces and the Lasix will cause the child to urinate all this excess fluid out through the urinary tract. So it eliminates fluid. We need to monitor potassium levels and other electrolytes. Cyclophosphamide, this is given if our corticosteroids are not effective. So we want to let the family know, again, this is immunosuppressant, so no crowds, no sick people around. So also use when resistant, like I just mentioned, when the child is either resistant to steroids or cannot tolerate steroids. So additional education is provided for Lucy's dad regarding her care. So which topics should be covered? Select all that apply. Children taking steroids often develop hirsutism. Yes, that means they'll grow hair on their face, which can kind of be shocking. So we need to make sure that the family knows this, especially if the child's going to be on long-term steroid use. Monitor Lucy's weight daily. Again, it can cause a weight gain. Relapses can occur with this diagnosis, so monitor carefully for changes in weight or edema. Yes, because this is a lot more prone to relapse than our AGN. So nephrotic syndrome can be something that goes on throughout their whole entire life. Check her urine for protein and glucose each day. No, we're going to check for protein, which we will have gross proteinuria, which will make the urine very foamy and frothy. But no, her glucose will not be elevated. Constipation is often a side effect of corticosteroids. No, more commonly, the side effect is diarrhea. So here are some slides where we're talking about comparing and contrasting patho and AGN and nephrotic syndrome. So I've kind of lined them up from left to right. We look on here. So with acute glomerulonephritis, we have inflammation of the glomerulus. So I've capitalized the I in nephritis and I've capitalized the I in inflammation. So it is inflammation of the glomerulus. And it's also known as nephritis or nephritic syndrome. So again, another I there for inflammation and glomerulonephritis. RBCs are present, lots of them. We have the cola or tea colored urine. The urine is very dark, so it'll look like your Coke or your tea. small amount of protein is lost. We still have some protein loss, but not a significant amount like we do in nephrotic syndrome. So the cause is post-streptococcal infection of the throat or skin, which occurs about 14 days after the infection. So that's the cause for AGN. Now, with nephrotic syndrome, sometimes it's not even known what causes it. More common causes are lupus, heart disease, diabetes, but mostly idiopathic. So with labs, anti-streptolysin, increased antigens, antibodies collect and congest and inflame the glomeruli. So all of those products, those breakdown products of the strep, is clogging up our glomerulus. So with nephrotic syndrome, most loss is albumin and immunoglobulins loss. So will increase the chance of infection and risk for clots. So those are the differences with patho. So let's compare and contrast AGN and nephrotic syndrome side by side, going left to right here. So with acute glomerulonephritis, we'll have decreased GFR, which leads to hypertension related to increased intravascular fluid volume. So with nephrotic syndrome, our blood pressure is normal or low. All of our fluid has gone out into our interstitial spaces, so our intravascular fluid is low. So we're going to have a low or a normal blood pressure. Urine characteristics with AGN, urine was tea or cola colored. I even made it the color right there on your slide that it should look like, that tea or cola color. Now with nephrotic syndrome, the urine is foamy and frothy due to the increased protein. Like I said, picture your Starbucks coffee with all that foam on the top. That's what your urine specimen would look like if you got it in a cup. So with AGN, we have swelling of the face and eyes. It's a lot milder than nephrotic syndrome, however. So with our decreased albumin in nephrotic syndrome, we have severe edema. So fluid goes to the interstitial spaces and not into the circulatory system. So severe edema with nephrotic syndrome. So we worry about hyperkalemia due to decreased urine output with AGN, and we worry about the significant weight gain with nephrotic syndrome. Okay, so now compare and contrast nursing concerns of AGN and nephrotic syndrome. I'm just going to read down through each one and then kind of discuss back and forth. So with our hypertension, with acute glomerulonephritis, we'll be giving antihypertensives and diuretics. With nephrotic syndrome, we'll be giving albumin so we can increase that protein level in the blood, help pull that fluid from the interstitial spaces back into our circulatory load. So fluid status, we're going to have strict intake and output with acute glomerulonephritis. Again, our urine output is 0.5 to 1 milliliter per kilogram per hour up to 30 kilograms. And then after we're 30 kilograms, we go with the standard 30 milliliters an hour. We're going to have hyperkalemia with acute glomerulonephritis. We're going to have edema. We're concerned about renal function here. And diet, fluid, sodium restriction. So we're especially going to limit fluids during periods of edema. And here, relapse is not common. So let's go back over and talk about nephrotic syndrome. So our big concern with nephrotic syndrome is infection, especially in edematous areas. There's a lot of edema going on, so we're going to have skin breakdown. This child is going to be very prone to infection. Blood clots, assess for signs and symptoms of blood clots, DVTs, and pulmonary emboli. Diet, we're going to decrease our sodium, decrease fluid, decrease fats and lipids. The fats and lipids are going to be high in the bloodstream because your body is trying to, the liver's ramping up saying what's going on here, and we start making all kinds of fats and lipids to try to replace that protein that's gone. So we're going to have a high cholesterol level in these patients. Meds, corticosteroids and immune suppressants. So we again have to make sure we're keeping the child away from other people, especially crowds, sick people, all of our good hand hygiene, and all the things we know surrounding infection, monitoring our vital signs for fever. So with nephrotic syndrome, I have capitalized this because this is important. Relapse is common. We will relapse with nephrotic syndrome more than once, more than likely. So the family will need to learn to get daily weights and check urine for proteins. So we're going to be teaching the family this before they go home with their child. So here's an illustration that might help you remember the differences between nephritic, is what we were calling it, because it can be nephritic syndrome, glomerulonephritis. So they're calling it by nephritic syndrome here, which is fine. Nephrotic syndrome, we have the O because we have O for O in protein, and then the I in nephritic syndrome for the I in acute glomerulonephritis and inflammation of the glomeruli. So that's where our I comes from. Cola-colored urine is hematuria, lots of blood in your urine. High blood pressure from increased circulating volume. Oliguria, we can't get, you see he's all stopped up there in distress, that glomeruli, he cannot get anything out, so decreased urine output. Nephrotic syndrome, we have the hypoalbuminemia, which means that we're urinating all of our protein out into our urine, and that's when our liver kind of ramps up and starts making lipids to try to replace the protein, so hyperlipidemia. Massive proteinemia, you see the urine is spilled over and the little dog is licking up that's kind of gross, but he's licking up the urine because it has lots of protein and is going to make him have a big muscle. Peripheral edema, severe edema. So that's comparing and contrasting. As long as you understand the patho, you'll be able to answer all the questions about this on your test. So our final discussion with genitourinary disorders will be hemolytic uremic syndrome renal failure. So we're going to talk about this case study and discuss our main risk factors and some manifestations that would validate our diagnosis. So let's read the case study. You are the nurse caring for a 2-year-old child who has presented to the emergency department with a history of nausea, vomiting, diarrhea, a loss of appetite, and complaints of sleeping all the time. During assessment, the nurse notes several areas of bruising and purpura on the arms and legs, along with complaints of small amount of urine found in the child's diaper. The family has just returned from a vacation in San Antonio, Texas. The child is suspected to have hemolytic uremic syndrome. What clinical manifestations would validate this diagnosis? So let's go to our next slide. So let's talk about clinical manifestations of hemolytic uremic syndrome. So nausea and vomiting can occur after an episode of measles, varicella, or having a UTI. Decreased appetite, lethargy, irritability, pallor, bruising, purpura, rectal bleeding, anuria, and hypertension in our more severe form of HUS. So when we're looking, though, at most of these cases, it is diarrhea positive hemolytic uremic syndrome. 90% of it is caused by E. coli. So E. coli is our culprit here. Anticipated labs for HUS. CBC, we're going to see a decreased hematocrit and hemoglobin. We're going to see an elevated reticulocyte count. That's our immature red blood cells that are trying to form more red blood cells quickly. Hematuria, proteinuria, elevated BUN, and creatinine. So class, that concludes our lecture content on genitourinary disorders. I have one final slide. I want you to know this formula inside and out for our minimum hourly urine output. So it is 0.5 milliliters to 1 milliliter per kilogram per hour up into a weight of 30 kilograms. So if the patient weighs over 30 kilograms, then our minimum accepted urine output is 30 milliliters an hour. So make sure you know that inside and out. And also, have a good day.